Dr. Liz Angelewski, and I'm the Director of Clinical Education and Training at Theralase. In this clinical education video, we will discuss medial epicondylitis, often called golfer's elbow, which is a painful condition of the elbow caused by overuse. The distal humerus has a medial humeral epicondyle and a lateral humeral epicondyle. The medial epicondyle is the bony common origin for the wrist flexors. Pain and inflammation at the myotendinous junction of this muscle group is referred to as golfer's elbow. Injury to the pronator teres and flexor carpi radialis muscles, which originate at the medial epicondyle, causes medial epicondylitis. Medial epicondylitis is usually found in the dominant elbow of a golfer. The incidence of medial epicondylitis may approach 1 to 3% in the general population, but is less prevalent than lateral epicondylitis. Medial epicondylitis is similar to the more common lateral epicondylitis or tennis elbow in many respects. It can be associated with racket sports such as tennis, as well as other activities including golfing and throwing sports. Medial epicondylitis is often due to overuse and repetitive microtrauma to the pronator teres and flexor carpi radialis muscles, leading to pain and inflammation. Smoking, obesity, increased age, repetitive movement, and forceful activity, managing physical loads over 20 kilograms, comprise the major risk factors for epicondylitis in the general population. Factors that correlate with a poorer prognosis include high physical strain at work, dominant side involvement, concomitant neck pain, duration of symptoms greater than 3 months, and severe pain at presentation. Patients with medial epicondylitis typically complain of medial elbow pain that develops gradually over time. The pain can range in severity from having a minimal effect on sports or work activities to severely impairing basic daily tasks and sleep. Symptoms are usually exacerbated by repetitive movements of the wrist and elbow. Medial epicondylitis is diagnosed clinically by the following findings: localized tenderness over the medial epicondyle and proximal wrist flexors, pain with resisted wrist flexion with the elbow in full extension, and pain with passive wrist extension with the elbow in full extension. Pain can be further elicited with resisted wrist pronation or supination and grip strength testing, particularly when the elbow is in full extension. Over 90% of cases can be managed successfully with conservative treatment. Initial management of medial epicondylitis, or golfer's elbow, consists of activity modifications, low-level laser therapy, and specific strengthening exercises. Patients should try to avoid activities that exacerbate symptoms and limit repetitive motion and forceful tasks. For athletes, correction of faulty biomechanics must be part of their activity modification. Low-level laser therapy has been shown to be effective in reducing pain and inflammation. Persistent or worsening pain, despite appropriate management, often prompts imaging and additional therapies such as a cortisone injection. The Theralase TLC-2000 therapeutic laser is well indicated and very effective in treating medial epicondylitis, or golfer's elbow. In a majority of cases, the pain and inflammation is reduced after the first few treatments, with subsequent healing of affected tissues greatly accelerated. It is recommended to have the patient seated comfortably with the affected arm resting on a table. Treat the medial aspect of the patient's elbow, starting proximally from just above the elbow and moving distally towards the forearm, and target the medial epicondyle and the wrist flexors. Treat the patient 2 to 3 times per week. Treatment protocols are customized by the Theralase TLC-2000 automatically based on a patient's physical characteristics. Pain will continue to decrease, and mobility will continue to increase with each subsequent treatment.